Good evening, everyone, and thanks for joining. My name is Rishi Kartare, and on behalf of Hetero Healthcare family, I welcome you all to the webinar on post COVID 19 complications management options, current and newer perspective. COVID 19 virus is evolving and mutating. Not only is it affecting lungs, but is causing various post COVID complications. We at Hetero Healthcare have always been in the forefront and along your side in this fight against this deadly virus. This evening, our esteemed and experienced doctors will share their practical experiences on the subject. With further ado, let me introduce you to the moderator of the evening, and it's my privilege to introduce Dr. Roy. So, Dr. Kshitish Roy is a founder of Dr. Roy Health Solution Multi-Specialty Clinic at Bandra. He's been a former medical director of esteemed Dr. Nifarkar's Asthma and Allergy Health Clinic in Dadar as a senior consultant, allergist, immunologist, and asthma specialist. Prior to returning to his hometown in Mumbai in 2011, he was a senior consultant at Columbia Asthma and Allergy Clinic in Vancouver, Washington, where he managed three busy clinics seeing both children and adults with variety of allergic, immunologic, and stress-induced disorder. Dr. Roy has been also an associate professor of pediatrics and medicine at University of MS Medical Center in Jackson, MS, where he also served as a director of Jackson Medical Mal Allergy Immunology Clinic from 2002 to 2010. He received his Bachelor of Medicine, Bachelor of Surgery degree at the Seth GS Medical College from the University of Bombay in 1996. He then completed a residency in pediatric at University of Illinois Hospital of Chicago in 2000. He went on to complete a fellowship in allergy and immunology at the National Jewish Medical and Research Center at University of Colorado School of Medicine in Denver, Colorado in 2002. He's authored a number of articles and publication from leading medical journals as well as book chapter titled Stress and Allergic Disorder for the two-volume textbook Psychoneuroimmunology, 4th edition. Dr. Roy has been a diplomat of American Board of Allergy and Immunology, a co-joint board aggregated by the American Board of Pediatrics and American Board of Internal Medicine. He is a fellow of American Academy of Pediatrics, the American Academy of Allergy, Asthma, Immunology, and American College of Asthma, Allergy, and Immunology. So Dr. Roy was listed as the best doctor from 2005 to 2010, and again in 11-12, as well as Guide to America's Top Physician from 2005 to 2010. So I welcome Dr. Roy and invite him to take over the session. Over to you, Dr. Roy.
Thank you very much, Rishi, for that kind introduction, and a very warm welcome to all my co-panelists, and also to a special thanks to Hetero Healthcare for organizing this webinar. Uh, Today, we are going to speak on a very important topic that we have all been dealing with in the last year and a half. And the more we deal with it, the more we keep learning on what it's really doing in our lives. And I truly feel that there is so much that we have learned in the past year and a half that it becomes very important that we talk about the post-COVID complications and their management options, the way they stand currently and as things evolve. Before we begin our topic of discussion today, I would like to introduce our panelists. We have with us Dr. Dinesh Kabra. Dr. Kabra is a consultant neurologist and stroke specialist at SIMS Hospital. Dr. Kabra completed his MBBS from Seth GS Medical College and KM Hospital in 1994. He then went on to complete his MD in General Medicine from Grant Medical College and Sir JJ Group of Hospitals in 98. Later on to complete his DM in Neurology from Seth GS Medical College, KM Hospital. He also has a fellowship in vascular neurology from Scollett School of Medicine and University of Western Ontario, London, Ontario, Canada. A very warm welcome to Dr. Kabra. We also have with us Dr. Vikrant Deshmukh. Dr. Deshmukh is an alumnus of the Government Medical College, Nagpur, from where Dr. Vikrant Deshmukh has completed his MBBS, followed by an MD in Pulmonary Medicine from St. GS Medical College and King Edward Memorial Hospital in Mumbai. Dr. Vikrant Deshmukh was awarded with prestigious fellowship by the European Respiratory Society for training in interventional bronchoscopy. He is a fellow of the European Respiratory Society, University Hospital Ancona. Dr. Vikrant Deshmukh Score competency includes performing an interpretation of pulmonary function tests, conducting sleep studies and titration, managing sleep disorders, CPAP, BiPAP, respiratory ICU management, insertion of the CVP, endotracheal intubation, phlebotomy, bronchoscopy, therapeutic, and the details of the rest are on your screens. A very warm welcome to Dr. Deshmukh. We also have Dr. Kapil Rathi with us today. Dr. Rathi has joined me on several of these webinars and has been an immense source of learning for all our audiences across India. He's a chest physician and infectious disease specialist from Mumbai, the director of My Health Clinic in Andheri, Mumbai. He's attached to Criticare Hospital and Roshan Group of Hospital in Mumbai. Once again, a welcome to Dr. Rathi. As we know, coronavirus is an old foe in a new garb. The old foe used to cause common cold, mostly in the winter months or the cooler monsoon months of the year. HKU1, NL63, 229E, OC43, we hardly ever studied about this except in microbiology because they are so ubiquitous and normal and don't really cause any serious issues. Then came SARS-CoV, which caused severe acute respiratory syndrome in 2002, 3, 4. And then we had MERS-CoV in 2011-12, the Middle East Respiratory Syndrome coronavirus. And both of these gave us a sound bite of what this virus could really do in its real form. But we had no idea what came with 2019 novel coronavirus, which has broken all rules and regulations of what this beta coronaviride family virus could do. Being 25 times larger than the SARS virus, it is far more infectious, transmit in the pre and asymptomatic phase, and has 4 key variants so far: alpha, beta, gamma, delta, with the delta virus now having spread to over 100 countries around the world and causing what may be the second, third, fourth waves in certain parts of the world, and certainly caused a pretty deadly second wave in India. We know that this virus enters through the angiotensin converting enzyme 2 receptors, which are largely expressed in the respiratory tract, the type 2 alveolar cells in the lung, but are also present in the esophagus, the upper and stratified epithelial cells, the ileum, the colon, the gallbladder, the heart, the kidney, the bladder, the olfactory bulb, the brain tissues, and along with the neuropilin 1 receptors, enters the nervous system and every part of it that we can think of. And hence, when we look at the dashboard of where it stands, we can see the number of cases globally, the number of deaths globally, and even with 3.8 billion doses of vaccines being administered already, and India having given about 44.1 crore vaccines, we still have only about little less than 10% of our population vaccinated with both doses. We still have a long way to go. Certainly, the seroprevalence surveys seems to point towards up to 67% people being immune. But we have to remember there are many parts of the country that are still untouched by this surveillance and also relatively untouched by the virus. The symptoms of COVID-19, as we recognize, can appear between 2 and 14 days from exposure of the virus, average being 4 to 5 days, with fever, fatigue, body pain, chills, headache, cough, breathlessness, nausea, vomiting, diarrhea, and then obviously the loss of taste and smell, which seem to be so unique to this virus due to multiple reasons, including edema of the olfactory bulb. Presenting as both asymptomatic and symptomatic, this disease clearly affects more than the respiratory tract, including the ocular, cardiovascular, neurologic, psychiatric, cutaneous, GI. The list can go on. And this virus has been detected in saliva, respiratory, blood, urine, and stools, just giving us an idea of how far reaching the effects of this disease are in the body. We know that this disease has various phases. There is a viral response phase and then the host inflammatory response phase. The stage 1 or the early infection, where there may be mild constitutional symptoms with fever, dry cough, on a blood test, lymphopenia, maybe slight elevation in CRP early on. These may be changes that may be seen. And as we go into the pulmonary phase, we start seeing the shortness of breath, with or without hypoxia, abnormal chest imaging and HRCTs, transaminitis, low normal procalcitonin. And clearly, as the viral phase ends and the host inflammatory response increases, we then go into the hyperinflammation phase where ARDS, shock, cardiac disease, and many other complications are seen with significantly elevated inflammatory markers which serially keep rising like CRP, LDH, D-dimer, ferritin, IL-6, troponin. And with this, we see that the common medications that we've had so far, the favipiravir, remdesivir, dexamethasone, oxygen, other steroids at low doses, are so important in the right phases for managing this disease. We do recognize that long-term sequelae of COVID-19 has a precedence in the past. SARS-CoV and MERS-CoV clearly caused impaired diffusion capacity for carbon monoxide and exercise capacity during the first 6 months following discharge, and even as much as post-traumatic stress disorder, depression, anxiety, which were significant in these patients. When we come to the pulmonary sequelae of COVID-19, we know that diffuse alveolar damage has been seen in multiple small postmortem studies that have been done in Europe and other parts of the world. Platelet fibrin thrombi, indicative of coagulopathy observed in small arterial vessels, are at the root of this, so is hemophagocytosis and immune cell depletion. So, a hyperinflammation, cytokine disarrays, and then clearly hypercoagulopathy that causes some of these problems. If we look at this case of a 57-year-old female who had complained of dry cough, no comorbidities, no honeycombing, but there was architectural distortion seen on HRCT, had mild restrictions, significantly reduced DLCO, post-walk desaturation of 5% with 220 meters covered. Just in a month, the patient was not on any antifibrotic therapy and the HRCT had significantly improved. So we have to realize that resolution does occur in the post-COVID phase and will occur in most patients, but we have to also realize that some are not as lucky. The extrapulmonary manifestations of COVID-19, which are there and can return or even be prolonged, especially the neurologic and the thromboembolic, is what we are going to focus on and discuss in today's panel discussion, followed by the questions and that we will take from our audiences who have joined in today. Clearly, the list is very long, and at the root of it, it is the virus itself, the inflammation it causes, and then the hyperinflammation that ends up causing the coagulopathic complications and the post-inflammation healing, which may go haywire and cause some of these issues. Long COVID is a well-known manifestation where patients may have brain fog for months after this infection. They may have persistent loss of taste and smell that may again take weeks and months to recover. Encephalopathy and stroke, we clearly recognize are issues. With pulmonary, the dyspnea, the cough, the chest pain, the post-COVID ILD, which is one of our focuses of discussion today. The others are well known, and even patients having cardiac issues, palpitations for prolonged periods of time, weakness, fatigue, inability to perform their routine activities. Many issues are there, and the psychiatric we have dealt with in other webinars. Recognizing that all the way to Parkinsonism, dementia, depression, PTSD, anxiety are clearly there in the neurologic and psychiatric sequelae. We have a lot more that we shall discuss today, including why this happens. Before we go into the actual webinar, being an immunologist and allergist myself, a note of caution or care to all the audiences and my colleague doctors: take care of your immunity. Fresh air, sunlight, a healthy diet, and exercise along with good sleep are the best immune boosters that you can find. Combine them with some of our ancient healing techniques and where necessary supplements, and take care of yourself so you can then take care of the patients just as well. We shall now discuss a case briefly and then go into our discussion with our panelists. Here, this is a 57-year-old male, post-COVID infection, no comorbidities, complains of breathlessness, dry cough, gastritis, oxygen level of 94% on 4 liters of oxygen at rest, a heart rate of 80 per minute, blood pressure of 130/90, having some crackles bilaterally on examination of the lungs, a CT pulmonary angio showing mild dilatation of the pulmonary artery, a mild pericardial effusion, no thromboembolism, and there's fibrosis with traction bronchiectasis that's already being seen. The 2D echo demonstrates severe pulmonary hypertension with a good left ventricular ejection fraction and a thin rim of pericardial effusion again. The spirometry shows severe restriction with severe reduction in diffusion capacity and a reduced total lung capacity. The post-lung desaturation, post-walk desaturation is about 9%, with a distance of about 260 meters that has been covered. When the CT of this patient initially was done, it showed a score of 16 out of 25. The patient developed pneumothorax and pneumomediastinum during the infection, subsequently went on to show pulmonary fibrosis with traction bronchiectasis, inter and intralobular septal thickening, mild dilatation of the pulmonary artery with no thromboembolism, was started on antifibrotic therapy, which caused some organization of the changes that were being seen. And clearly, fibrosis and traction bronchiectasis with honeycombing became even more evident as some of the active fibrotic processes started settling down with therapy. So this was a case of post-COVID fibrosis with pulmonary hypertension, clearly demonstrating to us the amount of devastation that this disease can cause in an otherwise healthy individual who would have probably never had something like this had he not contracted COVID-19 and had the issues that he did. Clearly, managing the pulmonary hypertension, reducing the fibrosis, and providing the supportive care, along with where necessary steroids, is still the line of management. And with that, I shall bring our first question of our panel discussion to Dr. Kapil Rathi. And I would like to ask Dr. Rathi, what do you think has been different between the first wave of COVID-19 and the second wave of COVID-19 when it comes to the manifestations of what this virus was doing? Did the Delta variant and the other variants that were there behave differently? Did we see a different picture to the disease? And how was it that this disease behaved in the second wave compared to the first wave? So your comments and thoughts on that.
Yeah, thank you, Dr. Sitesh, for that introduction and that question, and thank you, Hetero, in the outset for inviting all of us to have this good panel discussion and probably a lot of take-home messages to learn from each other. So coming back to your question about what was the difference, actually, what was exactly the difference? So probably difference was, there was a three things what I felt in the second wave as compared to first wave, because we were learning in the first wave. Probably we were more wiser in the second wave, but then actually virus fooled us in second wave in some way or other. That was the speed at which the virus was multiplying, or it has come to the virulence of the virus. It was more infective, it was more toxic to the patient. And the age group which this virus was catching up with the second wave was quite earlier. So it was more of a younger population, more rapidly, proving a really fatal disease. And three, it was actually causing more damage. So we are getting a lot of young people getting more sicker and getting into hospitals. So I think these were the three unique feature of this, and probably with some more symptoms which were not quite usual in the first wave, which were very evident in the second wave. Like we were having a lot of people having a lot of headache, a lot of loss of taste and smell was there, but nausea, vomiting, diarrhea, only headache, and body ache and something like that. Long-lasting fever was one of the very predominant feature in the second wave. In first wave, we have not seen that fever lasting for 4, 5, 7 days. But in second wave, we have seen that patient were febrile, and actually febrile means more than 100, 101 degree temperature for at least 4, 5 days. And actually, we were thinking, are we missing something? But that turned out to be COVID. So that was a very unique feature as compared to the previous. So there were subtle features which were in the presentation. Secondly, it was in the basically, the age group which it has happened. And thirdly, the rapidity which the virus actually make this patient sicker and making them more vulnerable for a more severe disease. So this was my first impression in the second wave as compared to first wave.
Sure, I think all those are very important points, and I think along with it, recognizing the degree of the volume of cases that we were seeing and the cluster spreading that we were seeing in the families, which we somehow did not see. So clearly, when the Delta variant came back with an R0 of almost 5, where one infected person would infect 5 people with a lower viral load also, I think we were seeing a lot more cluster spreading, and hence the peak number of cases crossing 4 lakhs per day at one point in this pandemic. So I think those are all very important points. My next question is to Dr. Vikrant.
Yes,
Dr. Vikrant, what I would like to ask you is, what would be some of the red flags or the risk factors that you would see amongst patients? Because we realize that 85% of the patients would be, 80 to 85 would be mild disease
Yeah.
Some would be moderate, and then there would be 5 to 7% that would get critical.
Yeah.
So, what were some of the red flags or the risk factors that you would say were
Yeah.
there for those patients who would progress and have a worse disease and a worse natural course during their illness? As an intensivist, I'm sure you've seen these in evolution coming to you. So, your thoughts and comments on that.
Yeah. So, as Dr. Rathia said, the first wave was a bit different from the second wave. And when the second wave started picking up, so we thought this may wave off over a period we thought, like in Nagpur, what we had was a topmost of 2,500 cases. And in the second wave, what we saw, the patients' red flag sign, like the younger patients were affected more, and it was very difficult to predict which patients were are supposed to go bad, because this was a variant there was a variant in the second wave. For me, the most important red flag sign is diabetes. Most of the diabetic patients, they landed up with hypoxia. Usually, they were fine for 5 to 7 days, and later on, they invariably, in spite of starting favipiravir, even on the day one or day two, they invariably landed up in having hypoxia, in having a severe disease. So, diabetes is one of the most red flag sign. Secondly, if fever is not responding, so that's what we saw in a second wave. If the fever is not responding after day 3 or day 4, invariably the patient's CRP, there was a delayed rise. The hyperinflammatory phase was there in even in the younger patients. And intractable cough is one of the red flag sign, wherein it shows there is a increase, there is underlying pulmonary involvement is going on, or it is more progressive, the disease is going on. Because in second wave, the patients whose CT score was say even 5, even the next day, it for all reasons the patient get hypoxic overnight, and his CT score for next day, that would be even 12 or 15. So such kind of things we have seen. So red flag signs from my side is, one most important is diabetes, intractable cough, and if your fever is not respond or is still persistent, fever is still persistent after 3 or 4 days. So that clinically. Secondly, if many times in this second wave we have seen happy hypoxia, patients were having less complaints, less manifestations, but they were hypoxic, and they were able to tolerate hypoxia as well. So of course, when we have a clinical examination, we used to get aware about it. So that's from my side about the red flag signs, wherein the patients should get indoor for management of COVID. Yeah.
Thank you very much, Dr. Vikrant. And I think when we combine that with some of the lab parameters that we may follow,
Yeah.
so progressively rising
Yeah.
CRPs, progressively
Yeah.
rising D dimers, as you said,
Yeah.
changing picture that we may see in their lab work, progressive
Yeah.
lymphopenia that might be there with an NLR ratio that goes from,
Yes, sir, of
two
course.
or
So
two and
like,
a half to
yeah.
3. I think all of these combined with what you have said would be
Yeah.
some of the key features that would help us identify who are those high risk cases. I'm sorry, you were saying something.
No, no, of course, I was saying the red flag signs from the clinical aspect.
Sure,
Then,
sure, sure.
yeah, investigating a patient, that will give us a more clear picture that which patient is progressing. The one variation what I have found, and of course we are going to discuss about the post-COVID complications. Many patients, they were having, though the CRP is normal, LDH is normal, the isolated D dimer, they were raised in many patients, and I only having hypoxia. Even the CT score was not that bad. So even the thromboembolic features, they were seen even as an isolated symptoms in few of the patients.
Very much, very much. That's a very, very important point.
Yeah.
Completely agree. We've all
Yeah.
had to see that. Dr. Dinesh, I'll come to you with the next question. My question to you is, as a neurologist and as a specialist, what were some of the common and uncommon manifestations of COVID-19 that you have been observing in the last year and a half, and especially through the second wave, that you would like to share with our audiences so that they become better informed about what are the different things that this virus can really do, and when it affects something where we would not routinely expect it to affect. So your comments and thoughts on that.
Thanks, Sudesh. Thanks, Hetero. As a neurologist, we were kept rather busy during the COVID wave. We were not directly managing COVID, but we got to see quite a few cases. Symptoms like anosmia, headaches, dizziness, these are extremely common in COVID patients. We got to see a lot of cranial nerve palsies in outpatients, facial nerve palsies, oculomotor nerve palsies. We have seen quite a few optic neuritis, ulnar nerve palsies, foot drops. These are in the outpatient settings. In the inpatient settings, we were asked to see patients in inpatient settings also. And I observed that delirium, encephalopathy, these are extremely common. 1 in 4 patients have some kind of encephalopathy. Then stroke, in our hospital, we did a sort of a small study. We looked at our patients that we admitted between April 1st and 31st of January. We admitted around 20 to 25 patients and 15 patients had stroke. So stroke is another not uncommon problem. It's among neurological problems, it is fairly common one. Then some uncommon problem that we have encountered is acute disseminated encephalomyelitis. We have seen a couple of patients like that. We have seen hemorrhagic encephalitis. You can see PRES syndrome, posterior reversible encephalopathy syndrome. Then we have seen certain rare peripheral nerve palsies, like we have seen bilateral phrenic nerve palsies. There are patients who are breathless and people can't find why they are breathless. And we have figured out that they have bilateral phrenic nerve palsies. These are some odd cases that we have got to manage.
Got it. Thank you very much. I think it just goes to show how extensive the involvement in the nervous system this virus really does, right from the acute phase, like you have mentioned, to the recovery phase, the changes including Guillain-Barré syndrome and all the other changes that can be seen is really something worth recognizing. And as you said, the strokes have been such a significant part of the COVID and post-COVID scenario. Where people who otherwise may not have ever presented with something like that have come in with those problems. Dr. Kapil, my next question is to you. And what I would like to ask you is, I know that there has been an investigation that has been used and abused during the COVID-19 pandemic, and that is the HRCT chest. Mm-hmm. So in terms of the high resolution CT scan of the chest, in your opinion, what is the right time to do it? And when it is done, is there a need to repeat it? I was in a very interesting webinar yesterday where the doctor said that having seen about 4,000 patients in the last year and a half, he's ordered an CT scan hardly less than 10% of the times, which was really a question for me, which has not been the standard of care. And I don't think none of us do that, but he was right that working in peripheral areas, you may not always have access to a HRCT. And sometimes a simple oxygen pulse oximetry with a 6-minute walk test can give you just as much information as that might. So having said that, as I said, a used and abused test, your thoughts on the right time to do it, when it should be repeated, and is it really relevant what the score is? Is it that important? Your thoughts on that?
Yeah, I think that's a very important question. Probably we have learned over a period of time. So how has to be done? In first wave, we were we all were learning. So we were probably more relying on radiology, and probably that was giving. And that time, the PCR was a problem. So you used to get PCR after 3 days, 4 days. So you were more on, yeah. So you have to do a clinical as well as radiological diagnosis to actually triage your patients right away, or so how to treat them. But in the second wave, but what has happened in the first wave, because that CT has got that much of importance, and there were all scoring system, CORADs and CTSI and everything, so that it become like a standard of care. At least in city like Mumbai and Nagpur, probably on metro cities where it is easily accessible and there are a lot of machines, probably 24/7, which was going on. And also because media and other things, they have said ki X-ray acha nahi hai, and CT is kind of more sensitive. So people were, they were taking risk and spending a lot of it. So in that process, a lot of people have actually gone and done CT with a probable diagnosis, not confirmed but probable, and they turned out to be negative. So that is where it is. So for me, if a patient who's an probable suspected patient, I'll actually wait for 4 or 5 days actually in the symptoms to develop, and then probably order a CT scan, because we all know radiology takes at least 4 to 5 days. That virus to travel from say nose into your lungs and everything, it takes 3 to 4 days to get into the pulmonary phase and get that symptoms. That is one thing. Two, I can do a CT scan on day one itself. The patient presented with like, an hypoxia or shortness of breath or happy hypoxia, what Dr. Vikrant has told us. So there are a lot of contraindicatory things what you can do. But as of now, for a routine walking, talking patient, if you want to do a CT, first of all, you can order on day 4 or day 5 of the symptom. So count your days of symptom and then you can order. Then probably that CT will give you more information than if you do it in the earlier phase. So that is what is we have learned. So probably before day 4, day 5 of a typical symptom, I think CT doesn't make any sense. But if patient is presenting to you, which most of us will be getting patient on day 4, day 5, because they will be doing all window shopping and probably some online or something else, or probably hiding the symptoms. So, but in the second wave, what we have seen, sometimes patient has become that symptomatic. Like day one, they were mild symptomatic, and suddenly within 2 days, they become bad or they become hypoxia. So probably that is the right time to do a CT in such cases. But for a routine cases, I think day 4, day 5 is the right time to do a scan. Probably I'll repeat my scan only if there is a clinical worsening or there are new symptoms or there is something which is new come up, maybe a new fever, new cough, or probably worsening, say from HFNO going to an NIV or going to an invasive ventilation, or probably I'll do one at the time of discharge if I see that patient still requires some oxygen or patient still looks bad, or really if I want to start something like antifibrotic, just want to assess the lung condition. But yes, CT does make a difference because it triages very well. We all know mild, moderate, severe according to the CT scan and practically correlate with the patient. The only point is that the CT done today may not be relevant after 2 days because the patient keep on progressing. So sometimes you have to take your clinical acumen into the consideration. You can't do repeat CT because it becomes so difficult for all of us to do it again and again. So it's quite laboring. So sometime on base of that CT and then clinical condition, you can correlate and you can formulate or you can aggravate your treatment as per the condition. Otherwise, there are very simple rule to do a CT scan. But again, all said and done, I think still it is more abused than actually used because a lot of people feel spending 4 or 5 thousand is nothing. You just go get a CT scan. Probably they get a false of a sense false of security because they do it on day 3, day 4, and then later on they turn out to be bad, which is a quite bad case. So we have seen cases who were not diagnosed initially because of normal CT, they turn out to be bad patient in the later phase. So that's why you have to do it very judiciously.
Very, very important points, Dr. Kapil. And I personally have taken care of some cases where they had no reason to do a CT scan and they were probably in day 6, 7, 8, 9 of the disease with fever, clinically otherwise very stable, doing very well, no other major parameters. And the CT scan came out so bad that they got so scared that where there was no need for hospitalization, they got hospitalized and actually after hospitalization had complications because of what I would call nosocomial or mismanagement also. So I think the CT scan can go both ways. And I think everyone here would agree that necessarily a CT scan that looks bad does not always mean that the patient is bad. So I think that that's also an important message for the audiences to recognize that the clinical correlation with what is being seen on CT is so important, as you rightly said. So my next question is to Dr. Vikrant. Dr. Vikrant, in terms of the severe patients that you may see, patients with severe COVID-19, um, what are some of the complications that you may say these patients may develop? What are the kind of things that as an intensivist you have seen patients with severe COVID-19 facing during their ICU stay and post ICU stay, if I may say? So your thoughts and comments on that.
Yeah. So managing a COVID patient, we have faced many different challenges, and especially during second wave, it was very difficult to even during counseling of the patients whether your patient is going to come out, because the response to the therapy was quite different in this second wave. In first wave, the patients were responding to remdesivir quite nicely, but however, in second wave, the response to remdesivir was not that good. Many patients required other biologics like tocilizumab, and when tocilizumab was short, even bevacizumab was used. So most common complication was progressive hypoxia. What we have seen, progressive ARDS not responding to steroids, antivirals like remdesivir, and even to the biologics like this tocilizumab this time. Secondly, many patients, when they required a higher PEEP or a BiPAP with higher pressures, a pneumothorax or a pneumomediastinum was quite commonly seen as one of the complications. Thromboembolic complications, resistant hypoxia, those patients, when they were evaluated with a pulmonary angiogram, they were found to have a good, like in the bigger vessels or in the right and main pulmonary vessels, they were having thrombosis. So even a couple of patients we have thrombolized and tried to treat the hypoxia by thrombolysis. Of course, they were in ICU setup, so they cannot be subjected to like endovascular thrombolysis. At some centers they are done. So pulmonary thromboembolism was commonly seen. Of course, in second wave, in the later stage, other complications like most commonly and feared complication was mucormycosis that many patients had suffered for that. And because of diabetes, few of the patients, because of thromboembolism, what we have seen was acute tubular necrosis, patient landing up with ARF. Few of the patients they had peripheral arterial thrombosis and developing gangrene of feet. We have couple of patients of those, and they landed up in having an amputation once their lungs improved and once their hypoxia improved. Uh, so these are the most common complications what we have seen because of the progressive lung damage and an extensive lung damage, wherein the CT score, so-called CT score, I would say, was about 20. The patient landed up with long-term oxygen therapy, and that was the most commonest complication seen because of the post-COVID lung sequelae, I would say, and some labeled it as fibrosis. And of course, as per my experience, most of the severe post-COVID fibrosis that has resolved over a period of 2 to 3 months. And of course, some unfortunate patients that which has not resolved, they are now landing up with a lung transplant. So lung fibrosis is one of the most common complication, I would say, that we have seen in ICU patients.
Thank you. And I think, Dr. Vikrant, what you've said essentially highlights that the focus of today's discussion, which is all the coagulopathic, microcoagulopathic, prothrombotic side complications that are there, and then the fibrotic complications in the lung, are really the key ones that are driving a lot of these diseases in the post-COVID phase, even after patients come out of sometimes a challenging course in the ICU. Dr. Kabra, I would like to ask you the next question. You've mentioned that, patients can have strokes during the course of the COVID-19 infection. They can present during the infection with stroke. They can also present in the subsequent weeks and months with strokes. Is there any difference between the strokes that are seen in COVID-19 that you've been observing and what you see in regular stroke patients that you had been managing for all these years for all the other reasons and causes that might be there? And is there a difference in the way that you all have been managing these COVID-19 related strokes, and what have some of been challenges been in managing them? So your thoughts and comments on that.
Big question, and a very good question, Satish. Uh, uh, we have seen quite a few COVID strokes. COVID strokes, first thing I would like to tell you is that many times we see stroke patients, they come into the casualty, they don't have COVID symptoms, classical COVID symptoms, and then we diagnose them as a COVID patient, and that COVID patient has a stroke. In fact, in our study, 50% of COVID strokes did not have COVID symptoms at the presentation. And there's similar experience in other neurological centers elsewhere in India also. That is one thing. So, in COVID times, any stroke that comes to the casualty is potentially COVID patient. Second thing is that COVID patients are a little bit younger than the standard patient that we see. Standard strokes that we see are between 55 and 75, 85. This is the standard age. But here we are seeing patients in 30s, 40s, 50s. These are more severe strokes. Clinically, they will have, on our stroke scale, National Institute of Health stroke scale, they would be around about 13, 14, 15, 16, 17. That means they are very severe strokes. Our standard strokes are NIH 5, 6, 7, 8. They are mild to moderately severe strokes. And many of these patients with COVID strokes, they do not have traditional vascular risk factors like hypertension, diabetes, heart disease, atrial fibrillation. So these patients basically have a stroke and we don't know what caused it. On a CT scan, we see in 1/3 of the patients, we see strokes in multiple vascular territories. That's a little bit odd in a normal stroke patient that we see. Most of the stroke patients have a stroke in one particular vascular territory. And when we do a vessel imaging, we see a lot of these patients have a large vessel occlusion, like they have a middle cerebral artery occlusion or a posterior cerebral or a basilar artery occlusion. And that explains why they have a big stroke. In terms of management, first thing is that we have a separate pathways of managing these patients. We have a COVID pathway where we keep our CT scan. Am I audible?
Yes, please. Yeah, we can hear you.
So we use all traditional protective equipment with us, and we have a different pathway of care for these patients. We bring these patients to a different route than the normal casualty patients, so that no other patients are not getting infected. We tend to do CT scans more often than an MRI scan because they may have hypoxia and other kind of things. Before we thrombolize these patients, we look at the coagulation profile that because these patients have some contraindications thrombolysis like severe thrombocytopenia, which is generally not seen as non-COVID strokes. Once we have figured out the treatment is same as for non-COVID patients, we thrombolize those patients where the thrombolysis is indicated. If there's a large vessel occlusion, we'll offer thrombectomy to them. And we do mechanical thrombectomy. And the risk of bleed is no different from non-COVID patients. So everybody who sees. One minute.
That's okay.
Yeah. So the treatment is we treat them in acute management, revascularization therapy. We don't differentiate COVID and non-COVID patients. But when we do a thrombectomy, we judge the patient regarding risks and benefits. If these patients have severe COVID symptoms, if they have severe hypoxia and from the COVID point of view, they have very severe disease, then we would discuss with the patient whether we should do thrombectomy or not. Because sometimes these can be a futile thrombectomy. So we are a little bit selective in going with the revascularization therapies. In terms of acute management, more or less standard acute management, we will give standard antithrombotic therapies. But if we have a patient who's got stroke in multiple vascular territories, and we have not found the etiology for that, if the stroke is cryptogenic, that means there is no large artery disease, there is no clot in the heart, there is no atrial fibrillation, still off-label, based on our clinical sense, we might give anticoagulation to these patients.
Got it. Okay. So clearly, this virus again has shown its colors and demonstrated quite a lot of things that we would have otherwise not seen or in routine observed. So I think that has made it challenging, and clearly neurologists across the globe, including yourself, have stepped up to the plate to kind of think outside the box, work outside the box, recognize that the first 4 to 6 hours are so critical in some of these cases. And when you're still trying to figure out is the person really COVID positive or not, and trying to get everything done, including getting them to the right place at the right time for the right treatment, I think it's been a real challenge that, again, that we have all heard and seen about a lot. My next question now, again, to Dr. Rathi, I come back to you. When we look at patients, we've heard from Dr. Vikrant about the risk of post-COVID fibrosis, and that being one of the worst outcomes that you can have in some of these patients. Are there certain risk factors that you would say a patient can have or shows for who might go on? We know that this is a very unpredictable disease, and we don't know, and we've seen people resolve, people not resolve. So one, what in your opinion is the about the percentage of how many people that you've been seeing go on to have post-COVID fibrosis, and are there certain high risk factors or features in their history that makes it more likely that these people need to be followed more closely? Maybe they need to be rescanned before they leave the hospital, and is there any role for early antifibrotic therapy in these patients?
Yeah, I think that's a very burning issue what we all are facing. And probably again, if you see the first wave, from there we have learned, and probably also learned from the SARS and MERS, how the lung was affected and how they have recovered. So as Dr. Vikrant has also told, and in fact you have also shown in your case presentation that case spontaneously regress. So typically in our practice, what we have seen in last 1.5 year, close to more than 5,000 COVID patients, only 10 to 15% of the patient are that vulnerable patient who can develop fibrosis. And probably out of that, 5 to 10% will require antifibrotic in some point of time for a longer period of time. So that is our data. Probably that will match to whatever we all feel and all international data is. Now, who are these patients? Now, these patients are, as the red flags, as Dr. Vikrant has told us, all your diabetic, hypertensive, ischemic heart patients, all comorbid patients, obese patients especially, and typically old age patient, underlying COPD, asthma, or a chronic alcoholic smokers. So these are the patients who are kind of a good recipe themselves to become maybe a fibrotic patient in the future. Plus patients who are sick enough to get admitted in the hospital and ICU, who stays for longer period of time, say more than 10 days, requiring a lot of oxygen, practically more than 4 or 5 liters per day for continuous 8 to 10 days, who are on high flow HFNO, NIV, and ventilators. So these are really a good candidate for to look them very closely in the future for getting into the fibrotic zone. Probably with this patient, I am going to scan at the time of discharge to see whether this patient has got some thickening of the septa, or there are some peribronchial traction, or there are some honeycombing, so that at least I can anticipate, and I probably can start in some patients at the time of discharge only some kind of antifibrotic. So these are typically a set of patients where you have to keep your antenna up, you have to evaluate them clinically. So again, patients who are going very well day 7, day 8, and then suddenly getting worsening and then coming back, these are again a group of patients who actually develop a lot of problem. Also patients who has presented with dense consolidation on HRCT on day 7, day 8, probably require oxygen initially, are again, so ground glass are like they are like a good markers for actually getting resolving. But the dense consolidation or that coalescence of the alveolitis is something which is very troubling to all of us, and we are actually seeing this patient turning out to be honeycombing and fibrotic. So these are some markers or some clinical features as well as radiology which you have to combine together and try to anticipate that this kind of patient might develop some kind of fibrosis. So you have to be proactive in such kind of patient in initiating antifibrotic, sometimes at least at time of discharge.
Correct. I think that's a very good summarization, as I would say, of the kind of cases that we have to be vigilant about, and what some of the ominous signs are that we need to watch out for, so that they can be intervened and possibly prevent the progression of their fibrosis, because we know that some of the antifibrotic therapies work best while the disease is still in evolution, rather than doing it after it is established. My next question is to Dr. Vikrant. Dr. Vikrant, we spoke about all the coagulopathic complications that you have been seeing in the ICU. And amongst these coagulopathic complications, what are some of the anticoagulant therapies that you all have been using, and what has been your protocol in terms of when the patient is with you all, when you all are discharging these patients? What are your choice of anticoagulants and therapy that you all do in these cases?
Yeah. So like we have seen two disorders, like two manifestation. One is inflammatory manifestation of COVID, which we usually treat with steroids. And the other is hypercoagulable state, which is usually treated with a anticoagulation. So those who are hospitalized patients, most of them, I would say 100% of those patients, they have received low molecular weight heparin. Okay. And just to avoid complications, we have to titrate even the dosing. Many patients, they had normal D dimer or say a borderline raised D dimer in few patients, but still depending on the profile of the patient, if they are older age, if they have a normal creatinine, normal kidney functions, I would go for DID doses for a low molecular weight heparin, full therapeutic doses, so as to avoid a complication of thrombosis in such patient, which can because these patients, they can land up with a delayed thromboembolic episodes of in form of a pulmonary thromboembolism or say stroke as well. So my first choice for the hospitalized patient would be a low molecular weight heparin, which I found quite safe. And I have not, like, hardly I had few patients just because of their deranged renal parameters, I have to withdraw or adjust the dose accordingly. Of course, on such patients on discharge, they were given oral anticoagulation, most commonly being used now there has been a dilemma. I have spoken to I have been on a forum of cardiologists as well, like which oral like novel oral anticoagulants, whether rivaroxaban or dabigatran is which one is better. So from their point of view, both acts equally well, and there is hardly any difference. So I have been using both in like even dabigatran on discharge of such patients. Even in OPD basis patients, wherein we found where patients were not having hospital beds for hospitalization, or few patients even being hypoxic, they were not willing for admissions. Like there were few patients who were having borderline hypoxia, and they were like afraid of going to hospital because they thought they won't ever come back from the hospital once they get hospitalized. So I have used even oral dabigatran in such patients or rivaroxaban. And in few patients, we have taught them to take self low molecular weight heparin once daily or even twice daily, and monitor D dimers after every 48 hours also. So as and they were visiting us on OPD basis as well for monitoring. So that's what we have commonly used. In the patient, few patients where the D dimer was not settling, like we see 1% of the patients, of all critical patients, they don't respond to the standard line of therapy, as in all cases, not only COVID, but however in any illness. So even in spite of having a full therapeutic dose of low molecular weight heparin, the D dimers are not settling, that which indicates, or they are still rising 4,000, 5,000, 7,000. So in such patients, we have used thrombolysis as well in few patients. But of course, they are usually critical patients and they don't respond to any line of treatment, most of them.
Got it. Uh, this is a question that comes up very often in terms of choosing between the various anticoagulants, and we shall come back to this because I already see some audience questions related to that.
Yeah.
But like you said, that most of them, the novel oral anticoagulants, have been performing well, and in reasonably well selected patients with no major risk factors, they do seem to work quite well. Dr. Kabra, my next question will be to you, and what I want to ask you is, do you feel that timely anticoagulation can prevent some of the neurological complications that we've been discussing? And if so, in terms of the choice of anticoagulants, I'm sure that just as Dr. Vikrant said, there have been even outpatient cases where anticoagulation becomes important because you start seeing some features, but they are not sick enough to require hospitalization yet, and they are not in that phase. So, your thoughts and opinions on anticoagulation from the neurological standpoint and from the general standpoint of COVID-19 also. Your thoughts and comments.
Wonderful question, Sudesh. Before I answer this question, let me tell you one thing. See, COVID causes thrombotic complication, but COVID also causes bleed. I think make this very clear. We have seen COVID increases the risk of intracerebral bleed. And these bleeds are not like non-COVID patients. These are not like basal ganglia, cerebellar pontine bleeds. These are lobar bleeds. These are bleeds that we get in non-hypertensive patients also. Anticoagulation is mainly for venous thromboembolism. For arterial thrombotic events, I would use anticoagulation when there is a traditional risk factor that warrants anticoagulation. Somebody's got atrial fibrillation. Somebody's got admission in an ICU and he starts having atrial fibrillation. That is not uncommon in COVID scenarios when they're very sick patients. They have a lot of inflammatory markers going up. They have cytokine storms. They can have cardiac arrhythmia. They can have atrial fibrillation. These are the patients who need anticoagulation. If there is a patient who got a lot of vascular risk factors and who's got a other indication for anticoagulation like DVT, I mean, those are the patients you can start anticoagulation and you presume that they will reduce your thrombotic arterial events. In terms of anticoagulation for preventing stroke, in certain scenarios, in 20% of patients, but in the 80% of patients, I have to be very careful because I'm worried about the bleed that it might cause. When a patient of COVID comes to hospitalization, we have to optimize the treatment for other vascular risk factors like diabetes or like hypertension. You might like to use statins, you might like to use aggressive control of blood sugar. You might like to see that the blood pressure is fairly fine. You might like to control temperature. Many of these stroke patients who have got COVID, they have got traditional strokes. What happens is that you have atheroma in the carotid artery or an intravenous vessel. COVID is the precipitating factor rather than the causative factor. Because of the inflammation, the plaque ruptures or there's a tendency of plaque to become unstable. So equally in terms of therapeutics, in terms of antithrombotic therapy, I would like to concentrate on a lot of other factors also that can be a risk factor for COVID. In terms of patients coming to the OPD, my process of evaluation is the same. If there is a reason for giving anticoagulation, if there's a traditional reason, I would give anticoagulation. If there is a person whom I think there's a stroke, I would do an imaging. There are multiple vascular territory strokes and I can't figure out why they are happening. I would give a short-term anticoagulation to those patients. On an outpatient patient, if there is no contraindication, I would give one of the NOACs, rivaroxaban, dabigatran, and apixaban. From the hunch of a neurologist, I would say apixaban is safest because it causes less intracerebral bleeds. Rivaroxaban is slightly unsafe from the point of view of neurology. It causes more intracerebral bleed. That's how I would approach.
Okay, all right, great. Thank you very much. I think that's a very reasonable and well-grounded approach that you have mentioned, where we have to realize that we can't become overzealous either. And we will come to the point of the dosage and what dosages are safe and what dosages are not based on the questions that I have. Dr. Rathi, I'll ask you the last question before we start going to audience questions, because we do have quite a few coming in. And I would like to request our audiences, if there are any questions you would like to ask our panelists, please feel free to send them in as we speak. We shall be taking them as we go ahead. So for all our audiences who have tuned in, feel free to send in your questions to the panelists and we shall be taking it in the next half an hour. Dr. Rathi, in terms of anti-fibrotic agents, between pirfenidone, nintedanib, there's always this question. One has been around longer than the other in terms of efficacy. Any differences in your opinion when it comes to post-COVID fibrosis, either starting it at discharge because the patient has high risk factors, or after when you're following them up? Your thoughts between these two anti-fibrotic agents. And we do have some questions on this, so I thought might as well raise it to you, and then I'll also come to Dr. Vikrant and ask him about the same thing.
Okay, so with both antifibrotic, now we are well versed. In fact, yes, pirfenidone is for some time now, so we have been using and we have been well versed, and we know how it acts and what need to be monitored. Nintedanib is something very new to us because of that off patency and availability by generic and Indian pharma. So it was quite affordable and available. So that's why it has come into the picture. And so if you ask me, pirfenidone is it's a basically down regulates the fibroblast and also the pro-collagen. So that is where it acts. Well, nintedanib are typically tyrosine kinase inhibitor. So it has got anti-fibrotic activity by inhibiting the PDGFR and VGFR receptors. So that is where it is more, I should say, more specific. So, but because it inhibits platelet-derived growth factor, so it has got a risk of bleeding also. So that is one need to be understand. So that is where it should be. Efficacy-wise, data-wise, nintedanib has always been a shade better than pirfenidone. If you ask me, as far as compliance and the ease of treatment or therapy is considered, nintedanib is much better. We all know, we have been using, and our patients are quite happy to take 2 tablets. Very easy to monitor, very easy to up titrate or down titrate. And there are very few things which you need to monitor once you start the medicine. Probably LFT and some bleeding, tendency what you need to monitor. That doesn't mean that pirfenidone is a bad molecule. Pirfenidone 2 is a good molecule. But the only thing is that dosing is little tedious and monitoring is little more difficult, or I should say. But there are little, interaction with, because there's a lot of polypharmacy which happens in COVID. So you need to be very careful what you need to choose. So given a choice with all the resources available, the availability, the compliance, and the side effect profile, nintedanib looks a better choice as of now for COVID patients. And there is a lot of data which is supporting this theory also, and probably getting more against placebo at the end of this year. So to me, as far as now, my choice remains with nintedanib with a dosing of probably 100 to 150 milligram twice a day. And then you can start at time of discharge, as we have shown. Certain subset of patient will require probably that. And then you need to give it for at least 3 months. That is what we practice. And then maximum you can give up to, it's very purely, individualized decision depending on the patient clinical and radiological scenario. But at least minimum 3 months is something which we all agree that we should give antifibrotic before actually it makes any difference.
Got it. This.
Hello.
Yes, please go ahead.
Yeah. So, means like I do agree with most of the points as told by Dr. Rathi. First of all, I would like to also shed some light on HRCT chest. What usually happens if a patient, say, with a score of 10 or 12 gets hospitalized on day 7 because of, say, hypoxia or cough or fever or breathlessness. And if we repeat a scan, even though his hypoxia settles off, because many times the patient wants to know whether his consolidation of pneumonia has resolved or not. And the CT score usually comes in most of the patients 2 points higher. Okay,
Yes.
so that is, we all know that radiologically it takes time to get resolved. And then the patients get panicked. And that's why my practice has been, if the patient is clinically fine, I don't usually ask for a repeat HRCT chest. As being a pulmonologist, we usually get a patients who are not responding to other specialists or say to other physician, and usually they have 3-4 scans with them. Like my scan score was say 20 and now it is 18 or now it is 16. Why it is not 0? So we have to explain to them, to the patient, that this is a scar marks and the scoring is same for all the scars what they are. So the CT score is not going to change for, so say, for next 3 months. So I don't ask them to do a CT every month, whether they have resolved or not. So my practice has been same. That's what we have told with the other doctor. I hardly ask for a repeat scan. Okay. So what my practice has been for starting an antifibrotic. Many times, most of the patients who have come to me, they have come with the complications of treatment. So like pirfenidone, because the COVID has given a power even to BAMS and BHMS of treating with remdesivir and steroids and low molecular weight heparin, and even GPs were using oral anticoagulants. Okay, so even they have started writing pirfenidone. So, and in a full dose. So they just, some medical representative tells them this is the dose. And it is very, we as a pulmonologist, we know that 1800 milligram of pirfenidone is very difficult to digest along with the other medications which we are going on. Okay, so my experience with pirfenidone is not that good, but however, when I have shifted them to nintedanib, and I have found a very good results in terms of compliance. Rather than compliance, the response to the hypoxia is quite good. Patient's cough settles a lot, breathlessness subsides, and of course, along with that, as an antifibrotic, even the ICMR has suggested inhaled corticosteroids. So, along with nintedanib, I have used inhaled corticosteroids in the this second wave. First wave, we were not sure what is happening in the lungs and which drugs are quite good or not. So we were not sure. So nintedanib is much better in terms of mechanism of action. As sir has already told, it's a tyrosine kinase inhibitor. It prevents and it improves the fibrosis. Even in the if we compare the data, what we've seen is traditionally being treated with interstitial lung disease for UIP pattern interstitial lung disease. So it prevents the progression of fibrosis. So that's what we want as well in the COVID consolidations or COVID post lung sequelae. So nintedanib, I have been using only nintedanib. I am not prescribing pirfenidone as such at present, and we don't have, of course, because it's been a short period for using an antifibrotic agent. So it's all personal experiences rather than we don't. Nobody has an evidence-based data with use of pirfenidone and nintedanib. I have discussed with my couple of friends in US and UK as well. So they cannot write pirfenidone and nintedanib even a post-lung sequelae because their system doesn't permit. Okay, there is no, because they cannot use it even as an off-label drug. So as per my knowledge, US or UK or Europe, they don't use nintedanib or pirfenidone for treating lung fibrosis. But of course, my clinical experience is like I have seen a good response in terms of lung treatment of lung fibrosis, along with, of course, steroids and inhaled rather than oral steroids and inhaled steroids.
Dr. Bikram, just taking it forward, there is an audience question
Yeah.
that has come in, and I think
Yeah.
Dr. Rathi answered it in his own way, and I'd like your opinion. Someone has asked, what is the minimum and maximum duration that you would suggest for, like, once you begin the
Yeah.
antifibrotic therapy?
Yeah.
What is the minimum duration you suggest, and maximum? We all understand that it depends on
So
the disease.
yeah, so it all depends on, yeah, it is an individualized treatment first
Correct.
of all. Okay, so as a pulmonologist, we read a CT scan ourselves. So if we find more of a fibrotic traction bronchiectasis changes or a honeycombing sort of features, that indicates the patient is having a more lung damage rather than just having a linear strand, okay, or a ground glass. So ground glass CT may not require an antifibrotic as well. Okay, so I would recommend, like what Dr. Rathi has told, we expect this post-viral fibrosis to get resolved of its own over a period of 3 months. Okay, so maximum response what you are getting with any antifibrotic, say it be an nintedanib or pirfenidone. I may not be aware that of some doctors they may have a good result with pirfenidone. Okay, so I may not have that clinical experience. So 3 months I think is a good sufficient time to continue nintedanib as an antifibrotic agents. So I say from May, we have been getting post-COVID sequelae patients, or say from April. So April, May, June. So now most of our patients, they are getting off nintedanib after 3 months of therapy. 90% of them. 10% of them, so like usually we start nintedanib for the severe cases. Okay, but uh, in 10% of the patients we have started nintedanib just to avoid lung fibrosis because their lung involvement was too high. Okay, because we never know how much fibrosis or sequelae they are going to have in future, especially the young patients. So those patients, they required nintedanib just for a month or two itself because they recovered of its own very quickly. So I think 2 to 3 months of duration is quite good. Secondly, Indian patients, they don't tolerate nintedanib 150 milligram BID, unless, because if most of them are like average weight is around 50 to 55. So 100 milligram BID doses, they are easily tolerated. And only in heavier patients, we used 150 milligram BID. Diarrhea is one of the very common problem which what we have experienced with nintedanib. So we have to take care. We can reduce the dose in few patients, or we can stop the therapy for few days and again restart at a lower dose.
Thank you very much. I think those are very good insights and very good points made. Uh, I have also heard this as the other side of the story, because from what you said, many a times these patients may resolve over a month or two or
Yeah.
three, even spontaneously.
Yeah.
So sometimes the devil's advocates will say, are we over treating people and should we just wait and let them resolve on their own? Which we realize has its downsides, because if they don't, we will have a more well set and well established disease which may
Yes.
not as well respond to the therapy. So I
Correct.
think that is something that is important. And like you rightly said, keep reassessing, keep checking their oxygen requirement, keep
Yeah.
checking their 6-minute walk tests as they keep
Yeah.
recovering. Be prepared to taper them off the
Yeah.
medications. I think those are very, very important clinically.
Even lung functions, sorry to interrupt, even lung
Yes,
functions, like after first wave, many of our like pulmonologists, they were avoiding lung functions in even in post COVID patients.
correct.
However, in second wave, we have done lung functions in most of the patients after 1 month of their RT-PCR being negative. Okay,
Yes,
so I have experienced that restriction, moderate restriction with a reduced DLCO, that has improved, and that has improved. The lung functions have returned to normal lung functions. The FEV1, the DLCO has improved to normal, and we have like reported a good improvement in lung functions after nintedanib and inhaled corticosteroids.
great. I think that's a
Yeah.
very important practical
Yeah.
guidance for all our audiences,
Yeah.
and certainly compared to the first wave, even I, because I practice as an allergist, immunologist, and
Yeah.
asthma specialist, have done a lot more PFTs now, because clearly some of my patients where I was only evaluating them with an exhaled nitric oxide because that is
Yeah.
a less
Yeah.
forceful blow, I've been more apt to doing PFTs
Yeah.
again and evaluating them better. So I think it's very relevant to the post-COVID state also. Some of the other questions that we have I will take now. There's a question from Dr. Vivek Rane, who says, what are the symptoms of lung fibrosis? I know this is a very simple and basic
Yes.
question, but either Dr. Rathi or Dr. Deshmukh, if you all can take this question.
Yeah. So
So yeah, Vikram, go ahead.
yeah, yeah. So, of course, lung fibrosis symptoms will be majorly a cough, which will be dry in nature, and that will be a persistent cough, and breathlessness. Many of the patients, they come to us for breathlessness. On auscultation, you will be able to appreciate basal crepitations or crepitations in because of the lung fibrosis. Getting a repeat scan, I won't advise again, but if we reassess the older CT scan, that will give us an idea that patient 1 month before must have had a score above 15, 18, or 20. And those patients, they are high risk for having a post post COVID lung fibrosis, that I would say. Now, there are many discussions whether to label it as a post COVID lung fibrosis, or terminology is being used is sequelae, because it resolves of its own, because fibrosis is a irreversible terminology in most of the like our medical terminology. So many doctors, they hesitate to use a word fibrosis, and what we use a better word post COVID sequelae.
Completely agree.
Yeah.
There's a question that we have on from Dr. Neeta. She asks clinical observations on when to start antifibrotics. I think we have already answered this, but since this has just come in, maybe the person joined a little later.
Yeah.
Dr. Rathi, you want to just very short and brief clinical observations on when to start antifibrotics?
So yeah, so antifibrotic, as Dr. Vikram has pointed out, so any patient, if you ask me post-COVID, say 10 days, 15 days, still not, getting resolved, getting fatigue, getting dry cough, or getting shortness of breath, which doesn't get resolved, or probably not improving on 6-minute walk test or something like that. And to start with, was a bad disease, or having a lot of comorbidity underlying. So these are the kind of patient where you will consider an antifibrotic. Again, I repeat myself: if there is a strong suspicion and clinical, we give it rather than hold it for a long, because whatever advantage it is going to give in that first 45 to 90 days, because after that, once it's settled down, then probably your antifibrotics are not going to work. So these are some subtle signs clinically, and probably if you've got something on back of radiology, you can actually correlate that. In some patients, as we have discussed, we can start at time of discharge only, but it depends on very individualist case based, where you've got a bad disease to start and patient is on LTOT, or probably, patient is not getting better and is getting discharged because of some other reasons. So there we can, but as a rule of thumb, basically disease which is progressing, shortness of breath, dry fatigue, getting little dizziness, unable to walk, or getting very trained out kind of a thing, that you can correlate with 6-minute walk test and probably imaging hand force. You can start antifibrotic on a strong ground, and you should start. What I think.
Great, thank you very much. I think that's a clear answer to a question. The next question that I have is in home isolated patients. So patients who have been confirmed to be RT-PCR positive, confirmed patients, any red flags that would indicate the need to start either anticoagulant or antifibrotic? I know this is a interesting question. Anyone who wishes to take it, please can go ahead. So home isolated patient, red flags to start anticoagulant, red flag to start antifibrotic.
Okay. So let me answer the first one. There is no role of antifibrotics in a home isolated patient. That is for sure.
Agreed.
Now, if you so probably we all are on the same page that we don't give antifibrotics to. So first of all, they're at home. That itself tells that are mild cases. So probably they don't have, their scoring must be less than 7, 8, whatever. So they doesn't require any kind of antifibrotic. Only except if they are previously in ILD cases, that's a different ballgame. Otherwise, if you ask the antithrombotic, yes, there are certain situations where maybe patient, because they're at home because of other reasons, because they don't have bed in the hospital, or probably they are sick enough or they are scared enough to go to hospital. So there are some subset of patients who are have typical hypertension, ischemic heart disease, COPD, asthma, obese, or having multi polypharmacy, immunocompromised, transplant, whatever. So this kind of patient, there is a role of anti-thrombotics, basically because they are high risk of getting. And we all know probably thrombotic complications comes up very late. Say they can come till 3 to 6 months post COVID also. And probably these have got a there's a right milieu inside that particular subset of patient where they can become pro-thrombotic and can throw a stroke or an embolism. So probably in some patients which are homebound or home quarantine or isolation, especially isolation with RT-PCR positive, with background of all these red flags, probably I will tempt to give them anti-thrombotic. Probably a NOAC. This is my drug of choice in this patient. So that is my take on anti-thrombotic, but obviously no antifibrotic.
And Dr. Rati, since we are on this, amongst the NOACs, any particular drug that you have had a preference for or liked, and if so, why?
To be very honest, whatever series we have got, we have using rivaroxaban. I'll put my hand on my heart and say, and typically the prophylaxis dose what we use is 10 milligram OD. We typically give it for at least 45 days, and maximum we are given up to 60 to 75 days. So 45 days is something which we all give. Now, why rivaroxaban? There are 2-3 points which we consider. One, because it is cost effective, it is available everywhere, with probably every pharma coming up with generic brand. Number two, it is we all know it's a direct inhibitor, so it is as good as dabigatran. Dosing issue is very easy, 10 milligram once a day, and probably doesn't have much interaction with other drugs. So that is one thing. So we don't want a drug which is BD, because there are a lot of polypharmacy which happens. Dabigatran has got that disadvantage. That is what we feel. Otherwise, rivaroxaban 10 milligram OD is for prophylaxis. For therapeutic, it's a different dose, but at least for prophylaxis, we tend to prefer rivaroxaban. Only if there is a issue with CKD or EGFR less than 30, then probably we go with apixaban. Otherwise, rivaroxaban is the way to go.
Dr. Vikrant, your thoughts on this same topic in terms of choice of anticoagulants and
Yeah.
dosage that you would.
I do agree with Dr. Rathi's comment that rivaroxaban has been the first choice, and like in some patients, we have used dabigatran as well, and apixaban in a renal patients with renal issues. So anticoagulation, like for me, like Novak is would be the first choice for the homebound patients, home treated patients.
Thank you. The next question that has come in is, can nintedanib and rivaroxaban be used simultaneously in patients? Because I think this is coming up because there's a little risk of increasing bleeds that is there. So y'all's thoughts on that?
Yeah, so if you ask me, we have been using, obviously the dose of nintedanib has to be 100 milligram twice a day. That is for sure. 150 will be too much. And if you want to use 150, you can still use 150 along with whatever anticoagulant you are using. So both way, anyways, anticoagulation what we are using is a prophylactic dose. So 10 milligram is not too much or not too less. It's kind of a middle path which we are taking. And nintedanib is what we are using. So only thing is that you have to monitor your patient. So don't let that patient write on the paper, say take it for 45 days and come after 45 days. So that should not be the case. You have to call them at least say within 5 to 7 days initially, just to see the parameter whether any signs. And you need to inform your patients that there might be something. So if they get any bleeding from any side or ecchymosis or something like that, they just have to inform. Otherwise, in practice, what we have seen, what have you is a, but yes, as at back of mind, you need to have that knowledge. You need to make sure that your patient knows what you are prescribing, and you need to tell them that what could be the probable side effect.
Any specific lab parameters to be followed, or it's mostly just clinical observation and follow up?
Yeah, we all know this. All NOAC doesn't require any kind of monitoring like PTNR or something like that. So probably the only thing is that we do just monitor D dimers in this patient if you want to monitor basically for a thrombotic kind of a complication. And obviously, maybe a platelet is something which we do in all these patients. So these are two things. Otherwise, for all NOACs, you doesn't have to do any PTNR for that matter. So I don't think you require. Only thing is that if there is a very visible clinical or something like that, then you have to investigate this patient. Probably stop. But otherwise, we don't monitor.
I think we are losing you, Dr. Kapil. I think you've gotten muted.
Okay, now you can hear me?
Yeah. We can hear you now, yeah.
So I think I just answered that. We have to just monitor probably and they just see also and see whether there are any active bleeding or something like that, a sudden drop in hemoglobin or something like that. That will give you fair idea to start. And probably 10 milligram doesn't bleed. That is what clinically we have found.
Thank you. I think that's clear enough. So maybe a CBC or D dimer, monitor those a little bit, mostly clinical monitoring and judicious dosing. That's the key. This is an interesting question. Will remdesivir be useful in the third wave if we have it? I would like to hear all of your opinions on that.
I think it will be like a blind card what we have been using in a first wave as well and second wave as well. So WHO is not supporting us, but I think remdesivir helps as compared to favipiravir, and let's hope like there is no other drug as such which can be used as an antiviral, good antiviral, but remdesivir has helped definitely in first wave. Second wave, I think the virus has fooled us a bit and it has mutated. And now it's not that responsive to remdesivir what it was in the first wave. Of course, in third wave, I think we don't have any other choice but to use remdesivir.
I
Till
guess we may have molnupiravir by then.
And
Yeah, yeah. But the
my
only
my
point is,
my opinion, just on as an antiviral, like my experience to favipiravir is not that good. Even what we use is in the mild cases. So in first wave, when remdesivir was quite easily available, and I have hardly used favipiravir. Okay, I have found many patients were not tolerating favipiravir at that time. The drug used to come in a 200 milligram tablets and not 800 milligram the packs in by most of the companies. And now later on, the number of tablets were reduced. So in second wave, when I have used favipiravir, so I don't find a bigger advantage in such most of the patients, like those who have diabetes. Even if we used favipiravir oral drug in mild cases, they eventually landed up with moderate or severe disease.
Got it.
Mm. That's my experience. Like that may be not others' experience, but that's my.
Good. Dr. Rathi, you wanted to say something. I think you had started. Um,
yeah. So yeah, probably third wave again. Believe me, remdesivir is going to be used. Whatever WHO says or whatever, we have to. There is no other RDRP inhibitor which is available as an in the IV form. And
Yeah.
remdesivir, we all know our local data from KEM and from Mumbai. It has shown
Yeah.
that Tosi and remdesivir both has
Yes.
got mortality benefit.
Yes.
So that
Yes.
is for sure. So it doesn't only decreases the duration of days, but it also
Yeah.
decreases the mortality. But only thing is that nowadays we all use remdesivir along with baricitinib. So that will be the combination
Yeah.
which is going to win you the battle against COVID. So probably not only remdesivir, but along with baricitinib, it is going to be a good cocktail of that two medicines that is going to be more effective. And we are using for last say 6 months, and we are seeing good result. Actually, better result than probably phase one or the wave one. But yes, again, the most important thing again remains is the timing. So you
Timing.
have to bang on the target. The timing has to be absolutely critical if you want to make a difference in that patient.
Yeah.
Completely agree. So I think the critical phase of somewhere between day 4 to day 9 or 10, if we can really get the stuff in there, the sooner the better. I think the results are very obvious to all of us who've been using these drugs. There's a question on relation of COVID-19 vaccine and thrombosis. I know this has been a hot topic with a lot that is yet to be learned. But someone has asked comments about COVID-19 vaccine and thrombosis. Now, clearly we are talking about anti-thrombotic therapy and stuff like that. We are not talking of any of that. I think the person is just asking our thoughts about the association of having thrombosis after COVID-19 vaccine. Anyone would like to comment on that?
Dr. Dinesh will answer that.
Yeah.
he must be saying a lot of post-COVID policies and everything. Yeah.
Yes.
Dr.
Yes.
Kabra.
Even for Dr. Dinesh sir, I have a question. Like post-vaccination GB syndrome or some myelitis patients have means like even if they may have seen, because lot many educated patients, they Google the post-vaccine complications, and that usually shows neurological complications in form of a GB syndrome or say myelitis, acute transverse myelitis. So that is seen with some other viral vaccines.
So we have seen GB syndrome with Covishield vaccine. I've not seen anything with Covaxin. And recently we had this TTS, thrombotic thrombocytopenia syndrome, in a young lady who had Covishield vaccine on day 3. If my colleague had this patient who had a large MC occlusion and a large stroke. On first day, platelet count was 1,65,000. Then it started to drop, and this patient succumbed. So, and on this one, we have seen quite a few patients who had arterial ischemic event after Covishield, and first 2-3 patients, like just after vaccination, we had 2-3 strokes, which happened on day 2, day 3. There is no way to say that this is because of vaccine this stroke has happened. but we saw a pattern in these patients. These patients were elderly patients. This is not TTS. This is a standard stroke. These are patients who are having a standard risk factor. They are elderly, and on day 2, day 3, they have a stroke, and their CRP is raised. Initial 3-4 patients, I did a lot of documentation and to see, what is the point to learn, and then I stopped doing it because I realized that this exercise is not going to be fruitful. The advantages of vaccine outweigh the small risk of stroke that might happen because of the precipitating event of the vaccine. So, and there is no way you can prove that this is a vaccine-induced stroke unless you have a large, huge database. There's no way you are going to prove that. So, somebody's asked this question, we can answer that, vaccine should be taken. There should be no hesitancy to the vaccine because, the number of ischemic event or thrombotic event or a neurological sequelae that might happen because of vaccine is extremely rare, and the advantages are much, much more than that. So here I go.
Just to add to that, Sputnik V, comparatively across the globe, now there are many concerns about the monitoring of that vaccine and post-vaccine complications, but there have been no reported thrombotic or stroke or those kind of events after that vaccination. Now, the question whether a chimpanzee adenovirus, which the human body has never ever seen, and hence responds in a very vigorous manner with the immune system, versus a human adenovirus, which the body has seen before, and hence may not have as intense of an immune response, whether some of these things make a difference, whether really it is lack of monitoring post vaccination, which is why those events were not picked up with that. There are a lot of unanswered questions, but I think as we realize that these vaccinations have been approved on an emergency use basis, there is a lot that we still have to learn about them, and like you rightly said, at this point of time, the message is, if you are eligible for the vaccine and the vaccine is available, take it, because the benefits clearly outweigh the risks. I think that's an important message. I think we have just completed our time. It's 9:02. I think we have managed our time well. We've covered most of the questions that have come through. I want to thank all our panelists today, Dr. Kabra, Dr. Deshmukh, Dr. Rathi, for a wonderful discussion. I think a lot of key and valuable information that our doctors, our colleagues can take back to their practice, can take back to their day-to-day management of these COVID-19 patients. We recognize that there will come a time when we will start to learn to live with this virus. It's never going to leave the human community. We all know that. Even if we get herd immunity, it's always going to be there. It may go from being a pandemic to being an endemic infection with small outbreaks at times when the virus decides that it's changed or mutated. But at the same time, we will be smarter at managing it, recognizing it, picking it up and treating it, and also hopefully preventing some of its post-COVID complications. So a very big thank you to all the panelists. Thanks to Rishi and the Hetero team, Mr. Sailesh, Mr. Shastri, and all of them who have worked behind the scenes to make these webinars possible. I think these are invaluable for our medical fraternity and our colleagues who are tuning in and will continue to watch it on YouTube and other places where it stays for posterity. A very big thank you to you all. Do take good care of yourself, and over to you, Rishi.
Thank you, Sitesh.
Thank you.
Thank you very much.
Thank you so much for joining. Thank you, Dr. Rathi, Dr. Deshmukh, and Dr. Kabra. And thank you, Dr. Roy, for moderating the session. And I can say that thank you for uncomplicating the post-COVID complications. So this is something which is very much needed, and it was needed for the hour. I wish you all the best in helping us in getting out of this a big atrocity that we are facing. And everyone, take care, be healthy, be happy, and keep smiling. Thank you so much. Good night to all of you.
Thank you.
Thank you very much.
Good night. Thank you.
Thank you. Bye-bye, everyone.
Bye-bye.
Bye.